is itself is a mystery for many physicians, because there is no direct diagnostic test available like rheumatoid arthritis, but there are certain clinical characteristics and certain sets of findings which will help us to identify and treat SPA effectively. So today our theme is little different from general garden variety spondyloarthritis, because it's known that spondyloarthritis is more commonly seen in men. Today we are here to discuss about the spondyloarthritis that can have presentations in women. So the theme of the general agenda of today's discussion will be case presentation, followed by a guest lecture by our esteemed speaker, Dr. Atul Deodhar. So I would like to invite Dr. Varsha Bhatt ma'am to coordinate the case discussion.
Good evening, everyone. On behalf of Department of Clinical Immunology and Rheumatology, Bharati Vidyapeeth Medical College and Hospital, Pune, I welcome all of you to this wonderful meeting today. We have Dr. Atul Deodhar, who is a world-renowned expert in spondyloarthritis, and we are truly blessed to have him today with us. Without wasting further time, I would like to invite Dr. Sri Lakshmi to start the first case. We have two cases for you, at the end of which we will pose a few questions or queries, and we would be delighted if Sir could dispel our doubts on each case.
Good evening. So going to the first case presentation. This is a case one. It's a 25-year-old lady with history of low backache for the past 4 years. Early morning stiffness lasting for 45 minutes, and she was evaluated for the same by her family physician. On evaluation, she was found to have HLA-B27 positivity with MRI showing bilateral sacroiliitis with erosions. She was started on NSAIDs, but she did not have much improvement with NSAIDs. And then she was later started on injection adalimumab by her rheumatologist and continued for 6 months. She she had good response to adalimumab. Later, she was tapered and stopped over a period of 1 year. After 3 months of stopping, she had severe bilateral hip pain and difficulty in walking and severe restriction of all movements of both hips. So in December 2023, she presented to us with bilateral hip arthritis, and this was an X-ray done on the day of OPD consultation. Her left hip intra-articular depot methylprednisolone injection was given. Post this, she had around 40% improvement in pain. And later she was advised on bilateral total hip replacement.
So as you can see, we had a young lady with diagnosed as atrial spondyloarthritis, already on anti-TNFs, but when she stopped the medication for just 3 months, she bounced back rather badly with very bad bilateral hip arthritis. She was wheelchair bound. She was in so much pain she could hardly move. So when she came to us, after the intra-articular steroid, she was a bit better, maybe 40% relief. So now I would like to ask Sir, please, sir.
Thank you.
So firstly, I would like to ask you, what would your approach be in this case? What would your next choice of treatment be in her? Should we go back to adalimumab or anti-TNF? Should we go on to JAK inhibitors?
Yeah. So, well, first of all, thank you for this invitation, and I'm quite honored. So this is a very unfortunate situation that within 3 months, this lady actually had rapid deterioration of her hips. We rarely see this kind of stuff in the US. This I used to see, I mean, this is, I got a friend in Brazil, and they see this very often. So involvement of the hip. So let me take a step back. Involvement of the hip. Hips are the most important joints to be involved outside of the spine. Shoulders would be number 2. And hip involvement is extraordinarily functionally limiting to the patient. If you think about it, and actually I know there are people here who are online, so on Zoom, so you won't be able to see me, but I'm going to bend, I'm going to come outside and show you how I bend and tie my shoelace, for example. So if my back is completely fused, I should still be able to bend down and tie my shoelace. what I showed them was if my back is totally fused, I should still be able to bend down and tie my shoelace, because bending forward is by flexion of your hips. And so normally when you and I bend forward with normal spine, we bend our spine, and that's what we measured in the Shower's test. But hip flexion is extraordinarily important, much more so than the spine involvement. And this is one of the problems of our, and now I'm actually talking about slightly going off what the question was, but I'll answer your question in a minute. We think about radiographic progression, and we're talking about MSAS units, right? Modified Stoke spine score, and that is new bone formation around the spine, and one MSAS unit, and we worry about, oh, is this person forming new bone, etc. That to the patient is functionally not that restricted as hip involvement would be. And hip involvement, in fact, is one of the missed radiographic progression that we don't really think about. This is somehow become very rare in Western Europe as well as in US, but it is still very common in Brazil. And this happened for this lady within 3 months. She actually had this. We wrote a paper about this in Chinese journal, Chinese medical journal, in fact. And I understand that I'm speaking in India, and then people cannot really afford adalimumab for a long periods of time. My request would be to reduce the dose of adalimumab, or make that, rather than every 2 weeks, make it every 3 weeks, every 4 weeks, but completely stopping the drug becomes a problem. So that's number one. Number two is I would restart adalimumab because she has responded quite well. And this has been done in the study in there was a study on non-radiographic axial spondyloarthritis where patients were all given adalimumab, and those who were in remission, those who were in actually inactive disease at 6 months. So it was an open label period for 6 months. And after open label period for 6 months, those who were actually ASDAS of less than 2.1, then they were randomized to receive either placebo or adalimumab. And of course, the patients who completely stopped, still about 47% of them stayed in remission, or actually at ID, ASDAS inactive disease, after 44 more weeks, compared to 70% who continued that. They didn't really reduce the dose to half, or did not really change that the way it was done in certolizumab cases. So anyhow, but the question here is, what should we do? I would start adalimumab. JAK inhibitors would also be good. I mean, I don't see any reason why not, but, and that's cheaper here. So of course, I know that it's used here. Role of repeat MRI after worsening, MRI of what?
MRI for spine and hips.
Spine and hips. So I think that hips on the X-ray itself, and whatever I quickly saw, but there is significant loss of joint space, and hip replacement is the ideal thing there. If you think about also the treatment guidelines, the ACR, SAA Spartan treatment guidelines, and there is one guidelines for active disease and one for stable disease. And for stable disease, and those are color coded. So the dark green, we specifically give to hip replacement, improves the patient's function dramatically. They may have completely fused spine, but again, hip replacement will actually improve their function, picking something from the floor, etc., which becomes impossible if your hips are involved. And if your spine is involved, you don't really get into wheelchair if your hips are normal. If somebody is in a wheelchair, that means their hips are abnormal. They cannot really be functioning without that.
So the last question would be pregnancy morbidity, because now she's a young lady. What pregnancy morbidities would you be expecting in this patient, given her disease activity and hip arthritis? How would we navigate her reproductive life?
Yeah, so hip replacement should help that, certainly. That would improve the function, and including delivering the baby, etc. I have one slide in my talk later on about pregnancy and axial spondyloarthritis, so I can reserve that for that. But anyway, pregnancy morbidity can be a problem if the hips are not replaced. Once the hips are replaced, then otherwise she might just need a C-section, because the normal delivery may be very difficult for her. So probably you'll have to, of course, speak with the OBGYN and consider for planned C-section. Yeah.
Thank you so much, sir. We'll proceed to the next case.
Coming to case 2, it's a 54-year-old female. History starts in 2019 with history of low backache and morning stiffness. She had no limitation of movements at that time and was treated with NSAIDs, and she felt symptomatically better. 2019 to 2022, she was almost asymptomatic. In 2022, she presented with complaints of restriction of movement, with cervical pain and difficulty in turning side to side. So in this video, we can see that this is her maximum cervical movement. She had difficulty in bending forward. Her BASDAI was 4.8 and BASMI was 6.8. Investigation-wise, she was HLA-B27 negative, and MRI showed bone marrow edema and bilateral sacroiliac joints. Her ESR was 68 and CRP was 23.6.
So I would again trouble sir for some more questions here. So here we had a 54-year-old lady who was just well on NSAIDs for 4 years, but was not unfortunately started on anything definite for a long time. And she came to us with only cervical movement restriction, less in the lumbar spine. And so we would like to know, sir, what is the choice of biologic in such a patient with only severe restriction of movements? And as cervical vertebrae, are they more involved in women as compared to men?
Yeah, so thanks. So both these points I will be speaking about in my talk, but since you asked the question, I'll steal my own thunder. And yes, the cervical involvement is more common in women compared to men. And this is also seen in psoriatic arthritis, if you remember. So in psoriatic arthritis also, and they may not be complaining of neck pain. They generally in psoriatic arthritis especially complain about peripheral joint pain and swelling, etc. But then if you ask them, then they will say, yes, my neck also hurts. And that X-ray I couldn't really see. It was very short time there, but can we go back?
Yes.
So this also is pretty small, but I think there may be some problem of facet joint here.
Yes.
But is there any, I don't see any syndesm of it. Can this be made?
Can this be made?
That's okay. Don't worry about that. Don't worry. I can only see some facet joint arthritis here. I don't really see any. Oh, very nice. So it's not dramatically bad apart from some facet joint arthritis here. There isn't any. I don't see much of syndesmophyte formation. Maybe this is really flat.
There are a few syndesmophytes, very small, tiny ones.
This one,
Yes.
I guess. That one there.
The lower one, just below that. Yeah.
Oh yeah. Oh yes. Thank you. Very small, thin syndesmophytes. So I don't think that is going to be. So that doesn't reduce your spinal mobility. This particular.
We have given her adalimumab.
Yeah.
So overall mobility is better after about 5 doses.
Right.
And she's overall feeling better, but she's complaining only about the neck.
Yeah.
The neck mobility is not improving. So
Right.
what should tell her? What
So
should we do?
TNF inhibitor is a correct choice to do, and of course, physical therapy would be a very important one. I can tell you the story of when TNF inhibitors first came into the market. This was around 2003. They were approved in the US for AS, and we already had them for rheumatoid arthritis, and we had patients who were completely fused bamboo spine. And the chief of my division was somebody called Dr. Robert Bennett, that you wouldn't know. But he had started a patient of his with fused spine, completely fused spine on anti-TNF drug. And he couldn't believe it. The patient actually came, and the first thing patient told Dr. Bennett was, my height has gone up by 1 inch or something. Rob couldn't believe it. Rob said that, how is that possible? So he actually called me and he said, can you take a look at this patient? And he says that his height has gone up. And so clearly anti-TNFs don't really get rid of your syndesmophytes. They don't really do anything to admit the structural thing, but several times people are bent forward because of the enthesitis. So there is so much of inflammation in the enthesis around your cervical spine and axial disease that they are not able to move their neck, and they are not really able to stand properly tall. And that's what the reason why this guy actually had 1 inch gained in height, even though he was still fused. And so the answer to your question is yes, of course. I think anti-TNF is a great choice. Physical therapy, of course, or physiotherapy will be a very good choice as well, in addition to. And including, I mean, she's young, I think non-steroidal and inflammatory drugs.
She's 54.
Which is young for me.
Thank you, sir. And another one is there any considerable difference in progression and course of the disease in females and males?
Yeah,
Vis-a-vis
to go
males.
back on that. You have these, where are your questions? I think we should.
Next slide.
Are there any differences in prognosis and course of XLSP in males and females? So can I answer this question in my next talk?
Sure,
I mean, I'm answering all the questions about my talk in this one, but the answer is yes. I mean, so but I got specific things and also about HLA-B20,
Yes.
sex differences in B20 positivity. I'll cover that in my talk.
Also other genes involved in other
Other
sex
genes involved.
characteristics.
I'll talk about that. Yeah.
Thank you so much, sir. I hand over again to Sabri.
Hello. I think this was just a trailer and things are yet to start and it's going to heat up. The discussion is going to heat up. I would request all the online participants. We have got from 32 to 33 online participants by so far. I would request online participants to drop their questions in the chat box. So we'll try to take up them at the end of the talk. So next session is the most awaited one, the talk by Dr. Atul Deodhar. For this session, we have chairpersons Dr. Kavita Krishna ma'am, who is head of the department at Bharati Vidyapeeth Medical College, Department of Rheumatology. And we have Dr. Praveen Patil, who is a consultant rheumatologist here in Pune. So I would request Dr. Kavita ma'am to come and introduce the speaker.
Sharing the slides. Hello everyone, good evening. There is an increasing data regarding gender and sex differences in axial spondyloarthropathy, but females are still underrepresented in clinical research, and this under-recognition results in delay in diagnosis and treatment and increases the burden in the female axial SPA patients. So today, let's learn from the experts. Dr. Atul Deodhar is with us. He'll enlighten us on the existing data on gender differences in spondyloarthritis, and this will increase our knowledge awareness so that we can manage these patients better. Dr. Atul Deodhar, MD, MRCP, FACR, FACP, is a professor of medicine and the medical director of rheumatology clinics at the Division of Arthritis and Rheumatic Diseases in Oregon Health and Science University, Portland. He is both certified in internal medicine and rheumatology, and is a fellow of the American College of Rheumatology and also American College of Physicians. Dr. Deodhar is a past chair of Spartan Spondyloarthritis Research and Treatment Network, an organization of North American rheumatologists dedicated to education and research in the field of axial spondyloarthritis. He serves on the steering committee of GRAPPA, which is Group for the Research and Assessment of Psoriasis and Psoriatic Arthritis. He served on the American College of Rheumatology's Treatment Guidelines Subcommittee and as the Associate Editor of the Advanced Rheumatology course by Associate of Health Professionals in Rheumatology. He has served the ACR in various capacities as a Vice Chair of the Annual Meeting Planning Committee, Member of Peripheral MRI Task Force, Association of Rheumatology Health Professionals Nomination Committee, and developer of ARHP Online Advanced Rheumatology course. He has served on the Rheumatology Board of the American Board of Internal Medicine. Dr. Deodhar is the Editor-in-Chief of Best Practice and Research in Clinical Rheumatology, has been the guest editor for Current Opinion of Rheumatology, Annals of Rheumatic Diseases. He is also the reviewer for prestigious journals like New England Journal of Medicine, Lancet, Arthritis and Rheumatology, Annals of Rheumatic Diseases, Annals of Internal Medicine, among several other journals. Research interests are axial spondyloarthritis and psoriatic arthritis. He has authored 3 books, over 300 peer-reviewed articles, several book chapters, and editorials. Dr. Deodhar has been a principal or co-investigator in more than 100 clinical trials, mostly focused on antitherapies for ankylosing spondylitis, psoriatic arthritis, and rheumatoid arthritis. But the closest to us he is because he visits Pune so often, and there's so many people, faculty and ex-students of Vijay Medical College who are here to meet you here, sir, today. It's because he completed his MBBS and MD degree from the University of Pune, India. He did his residency in Sassoon General Hospital and King Edward Memorial Hospital, Pune, India. Subsequently, he did his MRCP from Royal College of Physicians, London and England. He completed his fellowship in rheumatology at Oregon Health and Science University. And before that, a research fellowship in rheumatology at the Royal Cornwall Hospital, Truro, England. He's also been invited for the next edition of Harrison's Book of Internal Medicine to write a chapter on spondyloarthritis. So we are really honored to have you here today. So I'll hand over the session to Dr. Atul Deodhar. I'm sure you have a lot of questions. Even after the lecture, you can interact with him. Thank you. So, just in the laptop.
Well, thank you so much. I wish my mother was here to listen to all this. She would be so proud of me.
Yes, policy. All right. Well,
Thank you very much. So I'm going to speak on axial spondyloarthritis in females. This, by the way, I mean, probably most of you have seen this photo. This is from Oregon Health and Science University. This mountain is called Mount Hood. This is 11,300 feet mountain, or 3,300 meters. And this is actually from the university. We are looking east, and it looks exactly like this currently. It generally has snow on it throughout the year. And certainly this time of the year, it is spectacular. Some of you have visited that place. These are my conflicts of interest. I'm going to move this part here away. So the very first thing is sex and gender are not the same. And I thought I'll talk about this because people generally use these terms interchangeably, but they are not the same. Sex is used to describe the physiological differences between male and female body, you know that. And in addition to the X and Y chromosomes, there are things, there are changes with the hormonal levels, there are changes with the height, body function, organ size, etc., the composition, physiological process, pain mechanisms, immune processes, several things differ. Gender refers to socially constructed characteristics. So what is expected of a male and what is expected of a female, and what you consider yourself to be. Whether you consider you might be a male, but you may not consider yourself to be a male, etc. And then transgender, most of you know what that is. So your sex is one, but then you consider yourself you have different gender. Cisgender is when your sex and gender matches. So I'm a cisgender male, which means I was born male, and I also think myself as male. But it doesn't end there. Things get more complicated. So it may not be binary, and this is getting more and more. And so this, of course, has already happened or arrived in the US, about to happen here. So the top part here, non-binary, this part is about the gender part. So what it says here is this: non-binary is an umbrella term. And a person may be saying that I'm non-binary. And what does that mean is, so androgynous, this is a great example. So andro is, of course, male and gynous is female. So this is identifying or presenting as neither specifically. They want to say that I'm androgynous. I don't want to say what it is. But that is similar to gender queer. Gender queer is the person who does not identify with a single gender. But then that is also similar to gender fluid. So they say that my gender is fluid. So sometimes I'm male, sometimes I'm female, but I don't want to talk about that. Agender is that they said, I'm not going to tell you about what my gender is. So at my university, when I see the patient, their name is there, and their age is there, and then their sex, and there could be blank. And they want to be called they, not he or she. So you call them they. So this is about gender. But that's not the end of it. Down here is the sex. So if you think sex is simpler, right? But it's not the case. So here, this blue thing is, of course, male. And you probably cannot really see this. And I probably should have made this bigger. But anyhow, this is male. This oblong circle over here. And this oblong circle, the pink circle is, of course, female. But then this one, the yellow and the green is here, the patient's sex is not specified, but their gender is specified. Where here, their sexuality is not specified. So you may be male, but then are you going to have sexual relations with a male or another female? And so that is kind of shown over here. So, and I can't read this myself very clearly here. But you get the idea. It is extraordinarily complicated. And then, of course, we know that there are some people born who are neither male nor female, and that's just genetic. But then what happens when they prefer about their sexuality one way or the other? So in any case, I'm going to be speaking about this pink thing over here. So rather than confusing where I'm going to speak about, I'm going to speak about this female sex. I'm not going to talk about gender. And anyhow, so the gender identity can be very varying. We wrote this article a few years ago, and when we were talking about men and women with axial spondyloarthritis, we were talking about the sex and not the gender. currently GRAPPA, which is the Group for the Research for Psoriasis, Psoriatic Arthritis, is doing a study in psoriatic arthritis, not excess spondyloarthritis, called SAGE, S-A-G-E, sex and gender in psoriatic arthritis. And they are going to separate this out and really look at sex and gender. So don't confuse between sex and gender. And when you're talking about it, be specific that it is either sex or it is gender. And most of the time we talk about sex. So this actually figure is from that particular article. And this is also going to be my last slide. And this kind of summarizes most of what I'm going to talk about, though of course not the questions about prognosis and other things. So on the left-hand side is male and on the right-hand side is a woman. The phenotype, I'll also tell you what endotype is later on. Phenotype of male axial spondyloarthritis is much more axial involvement. So things which look kind of red here. So axial involvement, hip involvement, the sort of rib involvement, etc., is much more commonly seen in male sex, greater axial involvement. And this can be clinical as well as imaging. So also radiographically and also by MRI. Compared to women on this side, as you can see, there is much more peripheral arthritis in women. And then there is a lot of enthesitis, and this part gets red here. You can see my arrow right here. Yeah. So this is the edge of your iliac crest, and I guess in Pune they would say "Maji kambar dukte." Kambar dukte, of course, could mean anything. It's like in US they say my hip hurts, and hip for them is low back. Hip doesn't necessarily mean the groin. So similarly in Pune, kambar dukte doesn't really mean what is kambar exactly. You should ask them, point with your finger. So kambar here is basically where you wear your belt. And if that is very tender, I had a patient, actually I had a resident, I had a fellow he was a male fellow. He had ulcerative colitis and he had significant amount of enthesitis. And in the morning, he was always kind of fiddling with his belt because the belt was very, very uncomfortable for him. So iliac crest pain is kind of very typical of, and that doesn't happen in fibromyalgia. This only happens in spondyloarthritis. I had a police officer, and in police in the US, I guess police here also, but in the US, their belt is unbelievably heavy. They have got guns, and they have got taser, and they have got phone, and they have got keys, and they have got all kinds of stuff. And it is probably 15 pounds around their waist. And he was thinking of giving up being a police because he couldn't put it around his waist because it was that painful. Anyhow, that is both the examples I had told you were male, but in women, this part is extraordinarily tender and they have got more peripheral arthritis. I'll come to this later on, that males actually have higher IL-17 and TNF blood levels, serum levels, which are less here. Structural progression is much more in men compared to women. Having said that, if you see here, there is inflammation around the neck in this figure compared to this. And so women actually have more involvement of the cervical spine. Overall poorer quality of life, depression, anxiety, neuropathic pain, and fatigue and functional impairment is much worse in women. And what I haven't shown here is HLA-B27. That was one of the questions. HLA-B27 is more commonly seen in men with axial spondyloarthritis. And it being less common in women, that actually makes diagnosis even harder, just because they're female to start with. So let's talk about the epidemiology and burden of disease. So women, this is a general view of what happens to women with all kinds of inflammatory rheumatic diseases. So rheumatoid arthritis, of course, is 3:1, as we know, more common in women. Psoriatic arthritis is 1:1. Psoriasis is also 1:1. IBD is 1:1, but that's a little bit tricky because there's a small thing over here that it's before age of 25, it's more common in men compared to women. But later on, as the age advances, in fact, if you take 60-plus-year-old people, then Crohn's disease is more common in women. So, but it's more common in men in the early. Ultimately, it becomes 1:1. Non-radiographic axial SPA is 1:1, whereas ankylosing spondylitis is 1:2. And so when we were growing up and in BJ Medical College, we were told ankylosing spondylitis is a disease of men, 9:1. I don't know where that number comes from, 9:1. It may be, I've thought about it, could be because of bamboo spine. But ankylosing spondylitis was equal to bamboo spine. So bamboo spine is rare in women. Of course, it occurs. I got 3 women that I can clearly think of who have got bamboo spine. So it's not that bamboo spine doesn't occur in women, but radiographic progression is less in women. Ankylosing spondylitis, that's why in the olden days was only bamboo spine. Before that, you wouldn't call anybody ankylosing spondylitis. So that 9:1 may be a relic of past, which is not really true. It is 1:2, so 1 for female. So 2:1 male to female ratio, but not 9:1. So inflammatory diseases have a high impact on women. Inflammatory disease often affect women in the reproductive age. That was one of your questions as well. And this is an interesting statistics. On average, women living in the US have 1.8 children in their lifetime. I don't know what the statistics is for India, whether it is 2 or 3 or what. And about 50% of pregnancies are unplanned in the US. I don't know how many pregnancies are planned in India. And as a result, women with autoimmune diseases end up taking medication when they become pregnant. And in your case, we didn't really discuss what would the patient take, and generally certolizumab doesn't cross the placenta, and so we would prefer that over adalimumab. And so the number of women considering childbearing, they actually increase because the anti-inflammatory biologics that we have are so powerful and so good that women can become pregnant. Question is what happens to their disease during pregnancy, and I'll come to that in a minute. So this is women of childbearing potential comprise a high proportion of individuals. So on the left-hand side, it says that 18% of individuals in the US with these diseases, they are women of childbearing potential, and we are interested in this AS, and well, we're not talking about PSA, but the y-axis is percentage of women of childbearing potential. So about 16 to 14% of patients with ankylosing spondylitis and psoriatic arthritis in the US are women of childbearing age. The remaining are, of course, women and men. And here, the biologic use varies widely. So if you look at ankylosing spondylitis, it is 53%, and in psoriatic arthritis, it is 58%. So it is used more and more commonly in the US of the biologics, and we are quite comfortable using it in pregnancy. And most of the time, insurance companies approve certolizumab. If they don't approve, we can still give them, suppose if I give them infliximab, for example, or adalimumab. The only problem that occurs is when the baby is born, and it's the last trimester, we generally avoid giving these things because the baby, then giving them live vaccine. I don't know whether BCG is still used in India or not, but it is still used. So that's a live vaccine. And so that can be a problem if the baby has received some dose of a biologic intrauterine. And that's the issue, not really any problem with intrauterine growth retardation or other problems. So women who conceive with active disease may continue to have disease activity during pregnancy. So rheumatoid arthritis, we were taught, gets better in pregnancy, but that's not necessarily true. So 54% do improve, and the remaining 46% in rheumatoid arthritis women, it remains stable or gets in fact worse. Psoriatic arthritis, 60% improvement. The remaining, they have got mixed improvement or worsening. 32% have worsening. Crohn's disease is about 1/3 remission and getting better or stable. And in ankylosing spondylitis, and that was another question in one of the cases, but that lady actually had hip involvement. This is about worsening of the disease itself. 40% improved disease activity. 60% of the women, the disease can become worse or could be stable. Lupus, of course, systemic lupus, we get very worried about pregnancy because it really gets dramatically worse and renal involvement, etc. So it's a much significant burden of disease for women with axial spondyloarthritis compared to men. They have got lower quality of life. And in the top part over here, these are various measures that we use, instruments that we use, AS quality of life, Euro quality of life, SF36. And whichever instrument you use, and there are multiple studies which actually show that women compared to men have much worse AS quality of life, Euro quality of life, SF36, etc. And compared to men, women actually have greater disease activity, higher rates of disease manifestation. And this greater disease activity, this is important. If you think about what instruments do we use, BASDAI is purely patient-reported outcome. C-reactive protein, in fact, is lower in women compared to men. So ASDAS, ankylosing spondylitis disease activity score. We use CRP into that, but outside of CRP, everything else is patient-reported outcome. We don't have swollen joint count and tender joint count, etc., it being axial involvement. And so patient-reported outcomes are persistently worse in women. And that's the reason why disease activity is persistently worse. It's not the CRP, it's not the MRI, it's the PRO part of the disease activity which is worse. And compared to men with eczema, women with eczema experience longer delay in diagnosis. And I got a slide there in a minute. So women have a unique presentation and the disease burden. The diagnostic delay, there are several reasons. One is, of course, historical. I don't know what is taught now in BJ Medical College or FMC or Bharati Vidyapeeth as to what is the male to female ratio. But once you teach medical student, it is 9:1, then of course, you're not going to expect a woman to have axial spondyloarthritis. That's number one. But number two, when women complain of "Maji kambar dukte," so that probably is fibromyalgia, or must be psychosomatic, or maybe because of pregnancy, or maybe because of degenerative disc disease or something. And as I showed you in the earlier figure, they have peripheral arthritis quite a bit, and they've got significant amount of enthesitis, which definitely is thought to be, then people think, oh, this must be fibromyalgia. She's not really coming here for back pain specifically. And they have back pain, unless you ask specifically, they won't really say yay or nay. We'll talk about these immunological and genetic responses. And then inflammatory markers are lower despite having higher disease severity score. So disease severity score actually should be disease activity score, but I have directly taken this from one of the papers. Now, of course, you're not going to be able to see this until Arti, you can use this in your clinic. Close your right eye, and with your left eye, you can read the fourth line, then your vision is 20/10. No. Forget about that. But the idea basically is comorbidity. So this is from, we did that paper that we wrote, we did a lot of literature review. And what is shown in the first column, I'll describe to you what this table is, because you won't be able to read this even with 20/10 vision. So comorbidity, anxiety, and cardiovascular disease, depression, fibromyalgia, etc. The first column is, the second column is women, third column is men. And this is the odds ratio, and this is the p-value. So depression and anxiety and fibromyalgia is significantly more common, and the odds ratio, for example, for fibromyalgia is 6.8. This is for men and women with axial spondyloarthritis, and the numbers over here are the our articles, are the references. This is from our review article, as I said. But there are some interesting things here. So uveitis, this is Arti's interest here. So uveitis is, in one particular article, this is 0.79 odds ratio in favor of women. So more common in men. This uveitis, this particular thing it didn't really reach any p-value statistical significance. Ulcerative colitis, we didn't really find anything, but sleep apnea is more common in men as well. So there are some interesting changes or differences in the phenotype of a male versus female. Higher fibromyalgia, lower sleep apnea, lower uveitis, etc., much more depression. And this, of course, also you want to be able to see, and I'll show this to you a little bit later, the radiographic progression is less in women. In the cervical spine, it is different, but in the lumbar spine and the sacroiliac joint, it is definitely less. So this is the delayed diagnosis. So this actually was another review article. We didn't write this one, and they looked at several different studies. And the delay in diagnosis, on an average, they found was 8.8 years in women since the start of axial symptoms, compared to 6.5 in men. And partly this is, again, historical reasons, but partly because they present with peripheral arthritis, enthesitis, etc. Mortality, this is very interesting. This is a Swedish nationwide population-based study. So the Nordic countries, Sweden and Norway and Finland, they have got very interesting system that their mortality statistics is linked to hospital admissions, is linked to the pharmacy database. And they can do this amazing thing. The entire country of Sweden, how many people died and how many people were hospitalized. And I mean, it's unbelievable when they publish these kind of papers. So they looked at the mortality rates in patients with ankylosing spondylitis with general population, and AS 9.5 compared to controls 5.6. These are age and gender and sex, and everything else matched. And these are some of the predictors of mortality: lower level of education and comorbidities like diabetes, etc. But I want for you to take a look at this graphs over here. This is total. The blue is control, red is ankylosing spondylitis. So of course, the hazard ratio is 1.60, so 60% increased risk of mortality. But if you look at men and women, women actually have much worse mortality compared to men. I mean, 53% and 83% more. So it's not just that they have worse functional problems and more depression and more other things, but they actually die more often than men with ankylosing spondylitis. And I thought this was quite interesting. And I would have thought probably that they don't really die as often, but no, they die more commonly. Pain perception and fibromyalgia in AxSpA females. So this is another interesting paper, sexual dimorphism in the prevalence, manifestation, and outcome of axial spondyloarthritis. So pain processing. So, and this is one of the important part of that one of the table I cut and paste here. So cutaneous pain receptors, women actually have more sensory pain receptors in the skin compared to men. And so women feel more pain. Hormonal effects, this is, I didn't think about it this way. So there is no effect of estrogen, but there is a testosterone actually increases the pain threshold. So the reason why men feel less pain is the testosterone actually increases the pain threshold. It's not the estrogen that increases or reduces the pain threshold. Opioid receptor types are slightly different, kappa and mu, and so different responses to different opioids as well. So these are this is the endotypic difference. I'll come to that endotype in a minute. Fibromyalgia is a comorbid condition. So these are several papers from different people, and this is just what is the prevalence of fibromyalgia and spondyloarthritis, which includes psoriatic arthritis and axial spondyloarthritis as well. And this is one paper which I'm going to talk a little bit in my next slide, Anush. So they had 36 patients, 18 men and 18 women, and prevalence of fibromyalgia was 25% in total, but it was 50% in women. And here is the study. This is from Tel Aviv. Comparison of 18 women and 18 men with established ankylosing spondylitis. At baseline, both groups had similar bilateral sacroiliac joint involvement, BASMI findings, so their bending, etc., was very similar. Amount of peripheral arthritis was also, they matched for that, even though it is more common in women. Similar sed rate, similar, and then they were treated with very similar proportion with non-steroidals and DMARD, etc. Women were older, longer disease duration, and delayed time to diagnosis, 9.9 versus 4.1. And then women had more fibromyalgia tender points. And when they were asked what percentage of these people have fibromyalgia as well, that was the question asked to the rheumatologist. 50% of the women, but none of the men were given the concomitant diagnosis of fibromyalgia. So the reason I bring this up is women are missed and they're called fibromyalgia. But just because they got fibromyalgia does not mean they don't have axial spondyloarthritis. They definitely can have both these conditions simultaneously. And there is more prevalence of fibromyalgia in women with axial spondyloarthritis compared to men. And this is just one of the studies. Imaging, we spoke about this a little bit. MRI inflammation is much more common in men. So the blue here, all these blues are men and pink are women. So here it is sacroiliac joint. If you look at the sacroiliac joint MRI, the inflammation is seen in this particular study, 60% versus 40%. This is 35% versus 18% in the spine. Here's another study which looked at positive imaging. The definition of positive imaging was any abnormality by imaging, 78% versus 64%. Presence of syndesmophytes was 8% versus 1%. So this is what I was saying earlier, that the bamboo spine is less in women. It does occur, but compared to men, it is less. So females have slower progression of radiographic damage, less thoracic and lumbar spine radiographic severity, though more cervical spine involvement in women. And so the predictors of spinal damage progression, we know that male sex is one of the most important one. HLA-B27 actually is not shown here, but HLA-B27 is another one. Inflammation is another one. So C-reactive protein is lower in women. The MRI inflammation is lower. HLA-B27 is rare. Is compared to male, it is less. And so male sex. So that's the reason why in men, there is much more spinal radiographic progression. Now, interestingly, the X-ray here is of cervical spine, where it is actually more in women. So pathophysiology, apart from the phenotype, is the endotype different? So what is an endotype? So this is courtesy Wikipedia. So phenotype, we understand. Phenotype is an observable characteristic or trait of the diseases. So you know what a phenotype is, how does the patient look like? Without the implication of mechanism, it doesn't tell you the mechanism. Endotype, in fact, is the same disease which might have two different pathophysiologic bases. So endotypes are characterized by immunological, inflammatory, metabolic, pathophysiologic pathways that explain the mechanism. So in other words, is the axial spondyloarthritis pathophysiologically different in female compared to males? So that brings us to HLA-B27. HLA-B27, so this is the 50th anniversary of HLA-B27. It was the first paper published was in April 5, 1973 in the New England Journal of Medicine. So there were two groups, one at UCLA and one in London. And they were competing and they knew that each other they are finding and who publishes first was the usual stuff. So Rodney Bluestone and Carl Pearson, these were very famous rheumatologists at UCLA. And they published their findings on April 5th, 1973 in the New England Journal of Medicine about high association of HLA antigen W27 with ankylosing spondylitis. And interestingly, this paper, April 28th, 1973. So this was April 5th, and this is April 28th. And of course, the previous one was from UCLA, so it went into New England Journal. This went into the Lancet. Ankylosing spondylitis in HLA-27. I personally knew I don't know that he's still around, Dr. Sturrock. He is from Glasgow. And so both these things, and so this was, so 2023, it became 50th anniversary, the 50th year still goes on. So 50 years later, we still don't understand exactly how does HLA-B27 cause ankylosing spondylitis. This is the interesting part. I've written here on the left-hand side 4 different thoughts or the theories as to what is about HLA-B27 that it causes this disease. So HLA-B27, of course, is a MHC class 1 molecule shown down here. This is the normal looking HLA-B27. So this is a heavy chain and this is a beta-2 microglobulin and it's presenting a peptide. So one theory is that it presents this arthritogenic peptide to the CD8 T cell. Now, nobody has really found this arthritogenic peptide, but that's one theory. The HLA-B27 misfolding in the endoplasmic reticulum, and then this misfolding leads to endoplasmic reticulum stress, and that's another theory, and that leads to inflammation. All these things ultimately go through IL-23, IL-17 pathway. The third theory is that normally it has this heavy chain and beta-2 microglobulin small chain, but sometimes it gets presented as 2 heavy chains. So this is the dimerized heavy chain, and the natural killer cell or this NK cell that doesn't really like this bizarre looking molecule expressed on the cell surface, and it reacts to this, and this leads to inflammation. Jim Rosenbaum, who was the chair of my division, he put forward the theory that actually HLA-B27 gene changes your gut microbiome if you have that gene. So one of the studies we did, very interesting study, was at the age of 50 in the US, you get a colonoscopy. You get a colonoscopy. You're asked to do a colonoscopy. Your primary care doctor sends you, and every 10 years, then you get a colonoscopy. So we collected the gut microbiome of normal people undergoing colonoscopy at Oregon Health and Science University, and also collected their blood to look for HLA-B27. These were normal people who did not have ankylosing spondylitis. In Oregon, we found that the B27 prevalence was 10% in this. So 10% were B27 positive, 90% were B27 negative, just by chance. And then we also had ankylosing spondylitis patients separately. And when we looked at the gut microbiome from the colon and also from the duodenum, in people, healthy people with HLA-B27 was more similar to ankylosing spondylitis compared to those who were normal. And The only reason we could think was HLA-B27 somehow has changed their gut microbiome. These were 50-year-old people. I mean, you might think that some of them will develop ankylosing spondylitis. Chances are low because generally this condition happens before the age of 45, as you know. So maybe few of them might develop. So HLA-B27 actually might alter the gut microbiome. That's another one of the theories. Be as it may, there are people with HLA-B27 negative ankylosing spondylitis, i.e. the females. So how do women develop this? And we did this literature review, and then we found out other HLA-B allotypes such as B7, B14, B39, B60, etc. Some say that the innate immune system dysfunction, including the CARD9 and NOT2 gene abnormalities, and that can do that. The MIF cytokine, the macrophage migration inhibition factor cytokine signaling through CD74 receptor. These are all theories nobody actually has shown. Or gut dysbiosis, IL-23, IL-17 mediated inflammation. Now, this is of course also shown in patients with HLA-B27 positive. So I don't really buy that much. And IL-1 cytokine pathway, including IL-1 beta, IL-1 alpha, etc. So there are several theories as to HLA-B27 negative people, how do they develop? And I just put this up as it just makes us think whether the endotype is different. It's not just that the phenotype is different in females, but the endotype might be different. And so these are the phenotypic differences. HLA-B27 negative is more prevalent in non-whites, more prevalent in women. There's high frequency of peripheral arthritis, dactylitis, IBD, lower disease activity. So this is exactly what I told you about in women, less frequent radiographic sacroiliitis. So HLA-B27 is a risk factor for radiographic progression as well, less symmetry of syndesmophytes. So for example, IBD-associated spondyloarthritis, HLA-B27 is not related to that at all. With psoriatic arthritis, psoriatic axis involvement, there is B27 relation, but not with IBD association. This is a very interesting paper which came from Toronto, from Rob Inman's group. Many of you probably know Nigel Haroon from Toronto, and Nigel Haroon's boss was Rob Inman, and this is from his lab. Sexual dimorphism in Th17 signature for ankylosing spondylitis. So they took male and female ankylosing spondylitis patient cohorts with age and sex matched controls, and they measured their serum cytokines. They looked at the frequency of Th1, Th17 cell by flow cytometry. They looked at the gene expression analyzed by microarray and nanostring approaches, etc. And what is shown here is IL-17. This is on the y-axis here in the first figure, compared to healthy controls, and they only had 4 healthy controls here, as you can see. Ankylosing spondylitis, interestingly, these just missed the p-value. But then when they looked at these AS patients themselves, and here what is shown here is male to female. So this is in healthy controls. There are 4 people here, 2 male and 2 female. It's of course too little to get any statistical significance, but when they compared the male ankylosing spondylitis compared to female ankylosing spondylitis, serum IL-17A was higher in men. The same thing with TNF alpha. And this could be one of the reasons why females respond less to TNF alpha inhibitors and IL-17 inhibitors compared to men. So that brings us to treatment. Now, this is an old article. This is from 2013. This is about 11 years old now. Female patients with ankylosing spondylitis, impact of gender. Now, clearly they are confusing sex and gender. Now, next time when you read a paper, write to them and say, ha, wrong. But anyway, data pulled from 4 randomized controlled trials, active ankylosing spondylitis patient. This is etanercept, sulfasalazine, and placebo. And women were older, shorter disease duration, lower CRP, less B27. You know that. And women had higher burden of disease, etc., etc. But if you look at, so this is treatment by either etanercept or sulfasalazine. If you look at the percentage of people with ASDAS less than 2.1, so this is low disease activity. Less than 1.3 is inactive disease, as you know. So 41% versus 48% significant p-value there. ASDAS, well, let's look at this change in ASDAS more than 1.1. This is CII, or clinically important improvement in ankylosing spondylitis disease activity score. change of more than 2 is major improvement. So clinically important improvement and major improvement were also much more in men compared to women. So it was already known that women don't really respond, and this is with anti-TNF, but also with sulfasalazine for that matter. This is again from our thing, and you won't be able to read this, but here is the treatment response in male versus female. These are various different studies. AS or axial spondyloarthritis, and forget the study design and the male to female ratio shown here. And this one tells you about the relative risk RR. And so this is ASDAS, so relative risk is 1.4 for male versus female, which indicates that male are likely to respond better to a TNF inhibitor compared to women. And so there are several studies. I just want to show this to you to tell you that multiple studies, study after study, shows the same particular thing. This was presented at the ACR. I don't know whether this is published as a full paper, but this was actually, I took this from one of the posters that were presented. EXPA in men versus women real-world observational study. This was 5-year global real-world prospective observational study. You can see a large number of people in practice participated here. 1,385 patients with ankylosing spondylitis or axial spondyloarthritis. And they were searching for probability of achieving inactive disease or low disease activity in men versus female with diagnosis of less than 12 months. So this is kind of non-radiographic in a way. Well, actually they had some non-radiographic and ankylosing spondylitis as well. And forget the baseline. I want you to look at the year one, and here. And so interestingly, this was seen in the multivariable logistic regression analysis. Female 6 was independently associated with lower odds of achieving ASDAS inactive disease among patients with non-radiographic but not ankylosing spondylitis. So this is also pretty interesting to me that in these, and they actually took patients with recent diagnosis. For some reason, women with non-radiographic axial SPA, which is much more common, they actually have this. I'm coming to the end of my talk. I think this might be the last slide, if not the second last slide. Now, this is, I'm changing the disease. I'm talking about psoriatic arthritis, even though you asked me to speak about axial spondyloarthritis. And the reason I do that is this is this is a recent study. This was came to my attention just very recently, 2023. Influence of sex on the persistence of different classes of targeted therapies. This is from French health insurance database. So this is once you start a patient on the drug, how long would they stay on the drug? So this is drug persistence. And this is an indirect way of saying that they are responding to it. If they're not responding, they're of course going to stop the drug. So this is administrative healthcare database. So even in the US, every patient who gets the drug gets through the insurance company. So there are these huge 192 million patient database of insurance claims database. And that doesn't tell you the patient's history or anything, but that tells you the age and the sex and what drug they're on and the diagnosis. And this is from France. So this was all psoriatic arthritis patient, 57% were women, new users of targeted therapy. And they included all treatment lines. This first line therapy, second line therapy, third line therapy, etc. And the primary endpoint was persistence of the targeted therapy. And what it showed was the TNF inhibitor and IL-17 inhibitor were the two classes which was problematic for women. And this brings me back to that paper from Rob Inman's group from Canada, that the blood levels of TNF and IL-17 are lower in women compared to men. But look at these other drugs, IL-12, 23 inhibitors. Now this is, we are talking about psoriatic arthritis. So they're using ustekinumab, IL-23 inhibitor, JAK inhibitor. There was no difference. So the persistence was not lower for women than men for JAK inhibitor, IL-23 inhibitor, and IL-23. So maybe you guys can do a study and see whether JAK inhibitors, which is more commonly used here, is equally efficacious in men and women compared to TNF inhibitor. So treatment persistence was lower for women than men for TNF inhibitor and IL-17 inhibitor, but not for IL-23, IL-23 inhibitor, etc. So I thought that was very interesting. So I think this is my last slide. Oh yeah, this is the summary of my talk. This is the figure that you saw earlier. So in ankylosing spondylitis, female to male ratio is 1:2. Non-radical axial SpA, it is 1:1. And in females, there is delayed diagnosis, more peripheral arthritis, more enthesitis, more pain, more depression, more fibromyalgia, less B27, lower CRP, lower radiographic progression. Actually, I ran out of space, more cervical spine involvement, higher disease burden, higher disability, higher mortality, interestingly, lower serum levels and lower biologic response. All right, so I actually have 3 cases which I can quickly show you. What is the time? Can I quickly show you 3 cases or no? Actually, I shouldn't. I mean, this isn't really, we should probably open it for question and answer because 9:30 we have to stop and we only have 7 things. So in 7 minutes, we can, I can show this to you next time. Yeah, my flight is on Saturday, so I got time. Well, these are not very dramatic. These are interesting because these are 3 females, of course, and these are all 3 medical staff. One is a resident, one is a fellow, and one is a medical student. So this is a OBGYN resident from OHSU who has disabling lupus. So this was a 34-year-old lady, resident from Indian origin. She was referred by her PCP at OHSU to see me for hip, ankle, low back pain and positive ANA and positive double-stranded DNA. And she visited India in 2016 and had dysentery, myalgia, fatigue, and left buttock pain, severe enough to make her bedridden. So, of course, I told you already that bedridden, etc., may be the hip involvement here. But anyhow, the investigations in India showed ANA of 1 to 80, double-stranded DNA, low titer, other tests were negative. She was diagnosed as lupus and treated with prednisone for a month, non-steroidal for 2 months, sulfasalazine for 9 months. That helped, but the joints and buttock pain returned after stopping sulfasalazine. Then she came back to US and has been plagued with this buttock pain, ankle pain, thoracic spine pain, chest pain, recurring to ER visits, etc. Cardiac workup was negative. She kept on complaining of chest pain, and on inquiry, so I saw her, and all lupus and connective tissue disease related history was negative. She had excruciating tenderness of the left rib cage, right iliac crest, and no synovitis. And this is her X-ray of the sacroiliac joint. This is one of the best X-ray of the sacroiliac joint I'm seeing, very clean. And it's, to me, this is completely normal. Very good looking sacroiliac joint here. Normal looking hips here as well. ANA at OHSU was negative, but her double-stranded DNA was strangely positive. This always makes me wonder what that really means. CRP is 5, our normal 5 milligram per liter. This is 7.5, and she was B27 positive. And this is her T2 weighted stir image, where she has very classic bone marrow edema on both sides of the sacroiliac joint. Most of this ileum is involved, and here the lower end of the ileum is involved here. This is another slice of the stir image showing the sort of bone marrow edema. So the question is this non-radiographic axial SpA, is this ankylosing spondylitis, is it reactive arthritis, or is this systemic lupus with sacroiliitis? And I'm not going to pick on anybody here. And this last one, I don't really think this is the condition, systemic lupus with sacroiliitis. Having said that, I came here from visiting Dubai. I was in Dubai just 3 days ago, and they presented me cases like this. And they showed me a case of systemic lupus with sacroiliitis, and I couldn't believe it. And they said, yeah, well, there are case reports. And that case was actually biopsy proven, kidney biopsy proven grade 4, class 4 lupus nephritis. And there was no question about that. That patient had everything, full house. So I couldn't, and it was so odd basically because the patient actually was also 54 years old female with lupus, which was also pretty odd, starting at that age, presenting with lupus nephritis, biopsy proven, and she had classic sacroiliitis. Anyhow, and then I said that I have never heard of this, but they said, yeah, there are case reports, and ours is, you have one case?
I know.
Unbelievable. Wow. Systemic lupus and sacroiliitis? Publish it. Put it together and publish it. I have never seen that case, and I was most surprised. I mean, anyhow, so the question is, what is one of these things? And so the reason I show that is patients may simultaneously satisfy the criteria for multiple conditions. So here is XLSPA and peripheral spondyloarthritis. This is ankylosing spondylitis. This is non-radiographic. And the peripheral SPA has got psoriatic arthritis, reactive arthritis, IBD associated arthritis. And this OBGYN resident could be here. I mean, so you can call her reactive arthritis and you're right. And you can call her non-radiographic. She's clearly not radiographic because the X-rays were completely normal. But so patients may simultaneously satisfy criteria for multiple conditions. That was the only point I wanted to make. The take-home point is spondyloarthritis is a family of diseases. They simultaneously satisfy the criteria, and you can be called non-radiographic XLSPA with psoriasis or psoriatic non-radiographic XLSPA. In this case, you can call her reactive arthritis. You can call her in both ways. You will be right. Important enough to fully assess the patient and then look for other presence of various SPA features. This is a urology resident. Women generally don't go into surgery and less into urology, but this was a 34-year-old female resident in urology. She had 3 attacks of acute enteral uveitis since age 25, HLA-B27 positive, severe heel pain, and her problem was she couldn't stand in the operating room. She couldn't stand in the and non-steroidal physical therapy, special boot, corticosteroid injection, nothing worked. She was frustrated. She was in fact so frustrated, she was thinking of changing to family medicine, because when you're a resident and you cannot stand there pulling that retractor and the surgeon is shouting at you, then you think, maybe I should just leave this and go to family medicine. And so she never told me about back pain. She was referred for this. And this is the reason I bring this up is, if you don't ask them, I mean, her major problem is she's referred to me for her, I cannot stand in the OR, my feet hurt. You have got back pain? Oh, yeah, I got back pain also, but I'm here for my foot pain. But she had classic back pain, worse with rest, better with activity, morning stiffness of 90 minutes. 34-year-old female should not be stiff for an hour and a half in the morning. I mean, that itself is something is significantly wrong. And yes, she had plantar fasciitis, X-rays were normal. And strangely, this is United States of America. She was my resident, well, our resident. And MRI pelvis couldn't be done. The insurance said that, yeah, but you have to pay $500 out of your pocket. And she said, no, I'm not going to spend it. So can we diagnose her as XLSPA based on the information available? Yes, no, unsure. And I, of course, diagnosed her as XLSPA because not every patient with back pain referred needs MRI scan. I mean, I would have liked to do an MRI scan. X-ray was normal. But then we would order if the clinical suspicion is high, and we don't need actually we don't need an MRI scan if there are enough objective signs. I mean, she has got history of uveitis, right? She is B27 positive. She responds very well. She has got classic inflammatory back pain. Okay, who wants MRI scan? So I treated her as non-radiographic XLSPA. Last quick case is a medical student. 23, she's now graduated, 23-year-old female medical student referred for buttock pain starting at the age of 20. Sudden onset. This is not the insidious onset. This is sudden onset, left-sided, spread to the right side in 4 weeks, and unsure if exercise helped. So this is not very classic inflammatory back pain. And plus, it was radiating down her left lateral leg up to the ankle, not into the foot. So this was classically thought to be a radiculopathy rather than actually inflammatory back pain. Exercise lying down. So exercise or sitting or standing or walking worsened the pain. So not really inflammatory back pain either. Physical therapy helped. Very active, doing yoga and jogging 5 days a week, and non-steroidals helped dramatically. And she was seen by multiple people before she came to see us. She also had hip arthrogram, which showed no labral tear. Ischial tuberosity injections helped actually. No peripheral arthritis, no psoriasis, no heel enthesitis, no IBD, no family history, no nothing. And there was nothing on examination apart from some tenderness here and there, and some tenderness on Achilles tendon insertion and iliac crest again. So she was B27 positive, and this is the X-ray, and it's always the problem, and I cannot see the top end of this left-sided sacroiliac joint, but then there is a huge big colon sitting there. And we never really get very good quality of X-rays, and there is no real reason to repeat the X-rays again and again. So MRI was ordered because she had some of the IBP features, unexplained enthesitis, and great response to non-steroidal. So ideally, when you look at the MRI scan, the reason I put this up is this is the way we should really be seeing the MRI and showing it. And I'm sorry, I did not show you the OBGYN's MRI in this way. You should look at the T1 weighted image on the left-hand side and the stir image on the right-hand side, and they need to be corresponding to each other. T1 weighted image tells you about the structural damage, stir image tells you about the active inflammation. And this is the sort of irregularity here. Now, the problem with the bone is, Walter Maximovic says bone is boring on MRI. And the bone is boring because bone looks black on the MRI, on either side, whether it is T1 weighted or T2 weighted. I mean, which always confuses us because we are interested in, we always think about bone looking white. Anyhow, there is a little bit of bone marrow edema at the bottom here and on this particular side, on the iliac side. There's another slice looking something similar and similar looking sort of irregularity. Here, there is much more irregularity seen on the left-hand side. So the report was subchondral sclerosis, bone marrow edema, cortical irregularities led to a bilateral sacroiliitis. And we gave her full dose of non-steroidal. And the plot thickens because with 3 months of non-steroidal, she developed abdominal pain and severe diarrhea, lost weight and diarrhea, had some blood, and we referred her to colonoscopy that showed ulcerative colitis. And the gastroenterologist consulted me and we decided to start on adalimumab. And she did remarkably well. Overall condition goes into remission. So she called 6 months later. Her ulcerative colitis is still in remission, but the buttock pain has restarted. And we see this all the time, that one of the two conditions gets better, but the other one gets worse. So the question is, what should we treat her with now? So ulcerative colitis is doing well. Celecoxib, IL-17, infliximab, JAK inhibitor, IL-23 inhibitor, or plain IL-23 inhibitor. I don't know whether these drugs are available here. You get 23 and IL-23? No, you don't have that. All right. So IL-17 is definitely wrong. IL-17 would worsen her ulcerative colitis. So shouldn't be using IL-17 inhibitor. IL-12-23 inhibitor and IL-23 inhibitor, these will not work well on the axial skeleton. So those are out. So to me, infliximab, JAK inhibitor, celecoxib, non-steroidal anti-inflammatory drug, our gastroenterologists do allow me to use that in patients with ulcerative colitis or Crohn's disease. They think that this drug, the American Gastroenterology Society, they actually say that don't use non-steroidals at all. But then celecoxib is something with its magical properties. You can use that in IBD. So I would think it could be this or infliximab, or of course, here in India, JAK inhibitor is fine. So fine, those are my cases. This is another pictures from OHSU. This is looking east again. This is at Mount Hood. And we actually have this fancy tram, aerial tram, because our campus is up on the hill and one campus is down next to the river. And this is after a snow. This is how our medical school looks, which we had a huge amount of snow 2 weeks ago. We lost power. Thank you.
Sir, it was an excellent job. Questions? Yeah.
Thank you, sir. Excellent talk. I have 4 questions. One, you talked about the Lyme vaccine in patients with AS and use of anti-TNF during pregnancy, particularly in the 3rd trimester. So that recently I had reviewed the literature, and there's a mixed message in that. Particularly the IBD data suggests that giving in 3rd trimester does not make much difference to the risk of TB, because they have followed up those patients. And the earlier this story was developed around one patient developing neonatal disseminated tuberculosis. It was based only on that. And the further, so my question is, what protocol do you follow at the institute?
So we use certolizumab. We write to the insurance company and say that this is the only drug that doesn't cross placenta. And if you know, certolizumab basically doesn't have the Fab portion, and the transfer across the placenta occurs because of the receptor, the FC receptor. It only has the Fab portion, but not the FC part. And if there is no FC part to the molecule, so we don't even go for using any of the regular anti-TNF, but we specifically go to certolizumab.
The second question about the enthesitis versus the fibromyalgic tender spot.
Yeah. So the GRAPPA meeting is happening in the month of July, and I'm supposed to today actually I received an invitation to do a debate with somebody who's a very enthusiastic ultrasonographer, Sybil Aydin. She's in Montreal, and so people who can do ultrasonography, they will say good. I mean, they're very good at that and differentiate between active evidence of enthesitis versus fibromyalgia tender points. They will say clinical examination, I cannot differentiate between enthesitis or fibromyalgia tender point. I think it is waste of time unless there are certain areas, Achilles tendon insertion, they could look bigger, or the plantar fascia. But anywhere else, I mean, I do actually feel for where the patellar tendon goes into your tibia, or your quadriceps tendon inserting onto the top of your patella. But it's difficult to know whether that really is a fibromyalgia-related tenderness or enthesitis itself. It's enthesalgia. There is no such word. So ultrasonography is the answer to the question. And ultrasonography also will not differentiate whether it is physiologic enthesitis. And by that, I mean that if all of us go for a 5-mile run from here and come back, then do an ultrasonography on our Achilles tendon. Of course, there is going to be significant amount of enthesitis. There is going to be increased blood supply. So the most important thing that the people who do ultrasonography, they pay attention to is the Doppler signal. If there are erosions, then that could mean there probably is more likely to be immune-mediated inflammation. So ultrasonography can then distinguish between immune-mediated inflammation versus physiologic inflammation. But this whole area is kind of quite prone for mistakes, and you could possibly call somebody enthesitis when they really have fibromyalgia.
One more. Etanercept and uveitis. So a patient being on etanercept for a long time, for say a few months or a year, and then they have uveitis.
Yeah.
So how strong is the association that etanercept induced that uveitis, or it be in the natural course of their
So I don't think etanercept induces uveitis. Etanercept is not as powerful in controlling. Etanercept is as good as sulfasalazine in treatment of uveitis. It's not it is not as good as the monoclonal antibodies. So I don't think it will cause enthesitis, but it doesn't really. Uveitis. So etanercept and sulfasalazine. I mean, sulfasalazine has been used to treat uveitis.
It is the only drug which has some role in prevention of uveitis. There is one study where they showed that patients who were old study though, that had less incidence of uveitis.
Yeah. So I mean, yes. So it is effective even in treatment of uveitis. And etanercept I compare to that kind of like sulfasalazine, but it's nowhere close to infliximab or certolizumab or adalimumab for uveitis.
This is my last question, promise. About the non-radiographic, radiographic, and all these new terms, relatively new terms. So it's all about doing the X-ray first, right? And then say you had unrestricted access to MRI scan. Would you do away with the X-rays and just think from the MRI?
So no, I mean, so if the X-ray classically shows sacroiliitis, no question, I can save money. And so it's not true that we have got unfettered access to MRI scan. Insurance companies say no to that, and then why would you want to do it, etc., etc. It is safe, of course, no question about that. But we still do X-rays first, and if X-rays are very classic, unless the patient is in a study, I would not do an MRI scan if X-ray is good enough for me. X-rays do have a lot of, it's in the eye of the beholder for the grade 1 and grade 2. Grade 2 especially, grade 3, grade 4 is straightforward, but grade 2 can be very difficult. And so that can be a problem. But we haven't given up X-rays.
Ultrasound also.
Yeah, so no, I mean,
and then how good is the ultrasound for diagnosis of sacroiliac?
Ooh, I don't think so. Bone inflammation or the inflammation in that region, because ultrasound doesn't penetrate the bone. I don't think ultrasound would be showing sacroiliitis. We don't use ultrasound for sacroiliitis. We do use ultrasound for doing sacroiliac joint injection, but I don't think it will be for diagnostic reasons. Ultrasound is cheap, and so generally that is paid for.
Thank you, sir, for that excellent talk. I also have two questions. One relates to the first case that you have shown, although rare, but I do have a couple of cases who have unequivocal evidence of lupus with AS overlap.
Wow.
And biopsy proven, one is biopsy proven, other is clinical, high titers of PAD, PSC, some cytopenia, subjoint pain, but definitely axial spine involvement. Stuck there, can we use TNF blockers in such patients?
Yes, I think I would use it. There was a study which was done for, in fact, lupus nephritis, where they used Joseph Smolin is one of the authors, and he used TNF inhibitors in lupus nephritis. So TNF inhibitors is not completely contraindicated in patients with systemic lupus. So the answer is yes.
Just a request from online audience. Can you just repeat the question to for online?
Oh, so they don't hear that. Oh, I'm so sorry. Yeah. So, gosh. So I have to repeat all the questions that you were asking, the 4 questions. So the question, the last question was that the person who was asking the question has a patient with systemic lupus and sacroiliitis, and this was about the first case that I discussed here. And the question was if that they're pretty confident that this person has lupus as well as they got sacroiliitis. Can we use anti-TNF in lupus? And my answer is yes, you can use anti-TNF in lupus. There is a worry about this ANA and secondary development of lupus, etc. But no, you can use it, yes.
Second one, as you already know, we are using a lot of JAK inhibitors here, and strangely, we are seeing a side effect which is not very commonly reported from the Western literature, and that is massive weight gain of 10, 15, 20 in that range with tofacitinib, the generic versions. We're not using the original ones.
Yeah.
So is that your experience?
No. So I'll tell you what the Pfizer rep came and told me at your IRACon. He said that, look what is happening. These people are mixing tofacitinib with prednisone, and that's why they're weight gain. This is the Pfizer line. And so I said, really? They're gaining weight? And they said, yeah. So this is definitely not our experience. And so maybe you should get those drugs analyzed and see whether there's prednisone in there.
There is one question from online audience.
Yeah. And I didn't even repeat his question. I'm so sorry. Yeah.
So we'll be heading to next online question.
Yeah.
By Dr. Singh. So here are the questions. Do female patients with spondyloarthritis respond better to IL-17 inhibitors than TNF blockers? Yeah, answer this question.
Yeah. So, and I guess, so did the other people hear that question or they didn't hear the question? Online. Okay. So the online question is, do female patients with axial spondyloarthritis respond better to IL-17 inhibitor compared to TNF inhibitor? And I'm trying to think whether there is any such study. And as far as I know, I don't think so. I can't think of any particular study specifically looking at the response to IL-17 inhibitor in the female and response to TNF inhibitor in the female. So the answer is no, I'm not aware of this. No.
Just comment upon this radiological features, especially the MRI characteristics of sacroiliac joint, the bone marrow edema, the sclerosis, which actually really we have to give weightage to, and we
Yeah. So the question is, so I guess I'll paraphrase your question is, which features of the MRI scan of sacroiliac joint would indicate it's a positive MRI? Is that your question? Kind of, yeah. त्यांना माहित पाहिजे मागे.
Okay, and in addition to this, whether we can whether we can have something like false MRI. I mean, or maybe over-reporting of MRI as sacroiliac, and that would happen in which situation?
Yeah, so let me quickly, we're kind of going on and on here, and I'm so sorry about that, but I'll open another presentation here in a second. So this is a very nice paper. So this is now 2021 data-driven definitions of. So let me take a step back. So the original definition of positive MRI. Oh, the question was, I think it was extension of the first question, correct? The extension of the first question basically is whether, how do you define positive MRI? Is there something else you want to ask? Basically, that's what the whole idea is. So the original definition of positive MRI was in 2009, and that was consensus definition. So people kind of get into a room and then they decide what is the positive MRI. And that's what the definition said, that on T1, T2 weighted image on the stir image, if there are more than one areas of bone marrow edema, then that is positive. Or if there are two slices, one after the other. But that was not really data driven. Subsequently, this group, which is it's called Imagine group. This is ASAS group, which they looked at the data-driven definitions for active and structural MRI lesion in the sacroiliac joint for spondyloarthritis, and they did an amazing job. So they looked at the original database based on which the SS classification criteria were developed, and they had 7 readers, and they had to have 4 readers have to agree, and then the candidate lesion cutoff specificity 95%. I'll cut to the chase here. This part is the important part. Rule of 3-4-5. So this is the direct answer to Vijay's question about what is positive MRI. If there are erosions in more than 3 SIJ quadrants, or bone marrow edema in 4 SIJ quadrants, or fat lesions in 5 SIJ quadrants, and you have to, this is on the same slice. But if you add a 1 into this, so if you 4, so let me go back here, active inflammation. So here, bone marrow edema is in 4 SIJ quadrant, or 3 consecutive slices. So actually you subtract 1. So if the bone marrow edema is in the 4 SIJ quadrant on 1 slice, or 3 consecutive slices, there is bone marrow edema. Structural lesion erosion is in 3 SIJ quadrants or 2 consecutive slices, and fat lesion on 5 SIJ quadrant, actually there should be 4, or 4 consecutive slices. Then that is positive MRI. And then it is not, again, as simple as that. We kind of try to simplify that as just giving numbers, just counting it. It never is as simple as that. You need to look at the whole picture. This is just a guidance. They also say that these numbers, just giving numbers makes big mistakes. So you need to take into account the whole picture, and you need to rule out the other possible causes, number 1. It's hardly ever that you will see only bone marrow edema. You will almost always see some structural changes, such as fat lesions, such as erosions, etc. It's very unlikely, and in the very, very, very early stage, you may find some bone marrow edema, but then you will almost always find some fat lesions. You almost always find some erosions, etc. So you need to take into account the whole picture. But these are some of the guidance. So from 2 consecutive slices, bone marrow edema, it has become 3 consecutive slices, as you see here. And on 1 slice, rather than having 2, now that has become 4 SIJ quadrants. So SIJ quadrant is you draw a vertical line through the sacroiliac joint and a horizontal line. So they will become 8 quadrants. So does that answer your question too, or no? Yeah.
No, I'm talking about false positive.
Oh, false positive. Oh yeah, false positive. So here is false positive. So this is, and you probably have seen this figure, or rather this particular paper. So bone marrow edema can be seen in people, and maybe I should go to the one before that. This was one of the papers from Walter Maximovich's group. They looked at ankylosing spondylitis and this inflammatory back pain. This actually is non-radiographic axial SPA. Non-specific back pain, this is mechanical back pain, and healthy volunteers. People who don't even have back pain, if you do their MRI scan, up to 10% of them will have bone marrow edema by that old definition. They don't even have back pain, but they might have bone marrow edema suggestive of axial spondyloarthritis. Non-specific back pain, so mechanical back pain, you can have that. And then on the corollary, ankylosing spondylitis patient who definitely have ankylosing spondylitis, they have got changes. They may not always have bone marrow edema because they might have burnt out disease. They may only have structural changes. So 15% in this particular study with AS patients didn't really have bone marrow edema. And this is looking at the fat infiltration. So mechanical back pain, degenerative disc disease can cause bone marrow edema. Normal people with no back pain can have bone marrow edema up to 10% or so. And then the next slide is this one, which is this another study looking at 20 healthy recreational runners, 22 elite ice hockey players. The ASAS definition of sacroiliitis was met in 30%, 35%, 41%. Now, these elite hockey players clearly did not have ankylosing spondylitis, but that puts so much pressure on your, and then of course, we haven't talked about post-delivery. Postpartum women have bone marrow edema, and that can last up to a year or even 18 months or so. Up to 10% of women will have that. So postpartum period is also very tricky. And this is the important part, the one which is red. The posterior lower ilium or anterior upper sacrum. So this is looking sideways. So this is the anterior upper sacrum up here and down here, or posterior lower ilium. These are the areas. If that's the only place where there is bone marrow edema, then that's a danger area. Then that may not be really positive. So all these people, these recreational runners and elite hockey players and etc., they actually have bone marrow edema here. Postpartum women actually have bone marrow edema, which looks exactly like axial spondyloarthritis. The only thing what they don't have is erosions. So structural damage they don't have, erosions they don't have, but they have a bone marrow edema indistinguishable from the
They activate, they point that they postpartum the symptoms started.
yeah.
Usually feel just
So the question is, some of the axial SPA females say that postpartum their symptoms started. Yeah, yeah. So that's always very tricky. And then the bone marrow, the MRI scan has to be read, and then you should ask the radiologist, are you sure this is not just postpartum? Are there any structural changes there or not? That's what I would be doing, asking them.
How frequently would you come across a unilateral sacroiliitis with reported on MRIs where the phenotype is suspicion of an inflammatory back pain? And how do we go ahead? What would the frequency that you would really want to follow that patient thereafter?
Yeah, it doesn't have to be bilateral. So the question was how often we come across unilateral bone marrow edema. Quite common. Unilateral bone marrow edema has got equal amount of weightage in my mind as bilateral bone marrow edema. And I got another case of a young runner somewhere in my collection, which was a young male who was a 19-year-old boy who was running cross country. And he was told that you have got limb length discrepancy. That's why you have got unilateral bone marrow edema. And pretty significant bone marrow edema that limb length discrepancy would not cause. So I don't discount unilateral bone marrow edema as something, some other reason. Psoriatic arthritis can be unilateral, IBD can be unilateral, reactive arthritis can be unilateral with axial involvement, and even some stages of ankylosing spondylitis or non-radiographic axial SPA can be unilateral.
So can be COX, and that's why the problem is.
Tuberculosis. Yeah. Yep. I have got, you guys have so much experience about tuberculosis. I don't have tuberculosis experience at all. Or even for that matter, some other infectious disease, brucella. I mean, you don't get brucellosis. Those questions come in our exams. We only see those questions on our exams. They never really come in real life. The question behind it. CT scan. So the question is role of CT scan in sacroiliitis. Great question, and the answer is absolutely yes. CT scan is much better than MRI to show the bone, the structural changes. CT scan does not show active inflammation. CT scan shows the bone changes of erosions or sclerosis. There is a low dose CT scan. So regular CT scan is extraordinary amount of radiation and to the pelvis with gonads. And so we don't really want to irradiate the pelvis that way. But the low dose CT scan is coming in a big way. And the earlier question, I think you asked about whether we should just drop, one of you asked, X-rays and just go straight to MRI scan. Some people think that we should drop the X-ray, but do low dose CT scan that is way more better and less or much more predictable and much more the kappa value between two readers will be much higher than just doing the X-ray. So low dose CT scan is coming up in a big way in axial spondyloarthritis.
Can the unilateral sacroiliac joint inflammation in X-ray be because of the defective running technique?
The question is, can unilateral sacroiliac joint edema can be because of defective running? Depends on how bad the bone marrow edema is. Significant amount of bone marrow edema you will never develop on one side because of running or limb length discrepancy or something like that. I mean, if it is, it would be in the lower posterior ilium or anterior upper sacrum and very minor, without any erosions, without any structural change, without any fatty lesion, etc. So mechanical causes do cause bone marrow edema. It can be unilateral, but it won't be extensive, not this 3 slices and 4 quadrants and that kind of stuff. So the amount of bone marrow edema, the proximity to where the bone marrow edema is, etc., it matters. Size of the edema matters, etc., etc. So you can get it, but it won't be very extensive. Last question.
Sir, actually, we have a very interesting case. It's a 22-year-old male, already known case of eczema peripheral scar, and he was on etanercept. Initially, he had taken every week for 3 months, followed by monthly for 3 months, and he was on maintenance every 3 months only. He was taking was doing quite well. So he got admitted to our hospital with testicular torsion. That time only we were called, and while waiting, he gave some history of some recurrent diarrhea-like symptoms. So we did endoscopy, and some lesions were there. Biopsy was taken, and it came out to be non-specific colitis. So thinking of possibility of IBD, we started him on adalimumab. Sir, initial 2 doses, he responded a little bit, like 50 to 60%. But later on, his condition kept on worsening. Like we had to inject his knee as well as ankle. So we thought, why not to put him again on etanercept? And sir, with just 2 doses, he started walking, and all the pain and swelling subsided. So we still don't know that. They're thinking of reporting that case actually. It's a 22-year-old male. Actually, we don't say positives.
Yeah. So this was a pretty long and involved question. I don't think I'll be able to repeat the whole thing to the people who are listening online. But basically, this is a 22-year-old male who had back pain and who actually had, and he was on etanercept, and he has axial spondyloarthritis. And on etanercept, peripheral, yes. So he had axial plus peripheral spondyloarthritis. And on etanercept, he started developing diarrhea. And ultimately, it turned out to be that he had some lesions. It wasn't classical ulcerative colitis or IBD, right? So non-specific colitis. Non-specific colitis.
Didn't do well.
Yeah, and so was switched to adalimumab, and he did not do well. And the question is, and then they put them back on etanercept, and he's doing well. So, I mean, you see these kind of cases. Basically, that some people respond to one drug than the other, and I don't really have any good idea or answer as to why that happens. If you had told me that this person actually had definitely ulcerative colitis, and on adalimumab that got worse, and with etanercept ulcerative colitis got better, then that is publishable, I would think. But their back pain getting better, not with one anti-TNF and the other, that's that does happen, and I don't know why that is the case. Some people like Coke and some people like Pepsi. I like Coke Zero, but that's a different story. Thank you. Thank you very much.
Hello, Roshan, close the session.
Yes, sure.